So as far as the 12 lead EKGs, they're all going to be set up generally the same, okay, at least in the US. So for starters, they're going to be broken up. We'll split it down the middle, okay. You're going to have a left side and a right side, and you'll have some extra strips on the bottom. Your left side, okay, are going to be the limb leads, and the right side are your precordial leads. And then along the bottom, you have your running lead. Generally, this is going to be lead 2, as we see right here. It may also be 2 or 3 different leads. It may be a combination of, say, like V1, 2, AVF, etc. That just depends on how the machine is set up. Sometimes there might not be this lead along the bottom at all. As far as the limb leads, they're broken up. So you got leads 1, 2, and 3 going down here, then AVR, AVL, AVF. Okay. The precordials are going to go your 1, 2, 3, 4, 5, 6. All right. So they're all going in order and number. And this is, again, the general setup for most EKGs in the US. The other system you may hear of is called the Cabrera format, which is um, instead places them by their anatomical position in that order, which can be very useful. And it's still set up with the limb leads on the left and the precordials on the right. That one is just a little bit more useful for being able to see anatomically the relation, because right now you can see our inferior leads are up over here, right? So we have lead 2 is an inferior, lead 3 is an inferior, AVF that was an inferior here. And then we have 2 lateral leads, right? So AVL and 1. And then there are other lateral leads, so 5 and 6 over here. And then we have the anteriors, okay? And then finally the septals again up over here. Because I was running out of colors. But you see how it's kind of a hodgepodge as to where these are placed versus the Cabrera. They're a bit nicer for looking at. And the way this way is typically labeled is the lisal, or LISL. So that is your lateral, inferior, septal, anterior, and then lateral, right? So that's your lisal method. But now let's go ahead and start our actual interpretation for this EKG. So the first thing, remember, we have our 3Rs, which is the rate, okay? We have our rhythm, and then our regularity. Okay, so the first thing we'll do is going to be the rate, and in this case we're just going to do, because we don't see any weird stuff at first. Again, if you want to go do your atrial rate and ventricular rate, you could do that. In this case, we're just going to do ventricular rate. And I always like to find one where it's matching up to a big line, like I said. And there is an R right here. You see that's along this one. And also note our running lead and all these leads, it's along the same amount of time here. So these all match up to the same QRS complex, okay? It's just there's a time cutoff, and that's what's showing this. If this were V1 to not be here, we'd see AVR continuing on. Okay, so we'll use V2 here along the bottom to figure this out. And we go to our next one, which is going to be one box away from there. So we do one big box is 5, two big boxes 10, three big boxes 15, and we add 4 to that. Okay, so that is 19 of these small boxes. So we divide that, the 1500 divided by the 19, right? 1500 divided by 19. That's going to get us a rate of 78.9, and we're just going to round that up. So our rate here, I'll write down. So our heart rate is 79. Okay. As far as our rhythm, okay, if we want to go, we could do the laddergram, and we could draw this down here, right? So we could do our A, V, V, and then we'd see that each one of these, they're narrow complex, right, going down here. So we know it's coming from the AV node. It's coming here. It's doing that each time, right? And we do have these P waves here, so we can match that up. So we see it's originating from the SA node, okay, because we have those nice P waves. It's a narrow QRS. So it's going normally from the SA node to the AV node down to the ventricles and the bundle branches like normal. So this here is a sinus rhythm, okay. So our rhythm is going to be sinus. Okay. And then our regularity, we don't see any irregularities here. If we were to go and measure these out, a way I like to do is take a post-it note. The proper way is using calipers. Post-it notes are more available. You can go and just mark on here if you laid your post-it note up against here, right? Let's say you had a green one. You'd go and make your first mark here for this guy, and then your mark for this one, and you just march this out here. So as you move the post-it note down here, you'd see these are all matching up. So there is regularity. I'm just going to do a check mark for this. The next one, remember, we're going to look at the axis. So again, my preferred method is using lead 1 and AVF, and we see they're both looking up. If we use our thumb method, we know that's 2 thumbs up. That's good. So that's a normal axis. Okay, and now we're going to go to our 3 eyes. So our intervals, okay, our ischemia, and then irregularities. Okay, so our intervals, the ones we're going to care about, the PR interval, the QT interval, and we're going to do a QRS as well. Okay, so our PR interval is going to go from the start of a P, and we'll see if we can find one that's pretty. And for any of these also, you see there's different morphologies because we talked about each of these leads looking somewhere a little bit different. So just find the one that looks the nicest. Okay, in this case it's a lead 2 over here, and I'm just going to use this one right here, which is one shy of the big line. And if we go to the start of the QRS, right, and we can check this up and down here because these all again match up, and we see it's the 3 in here. So we had that's one small box, 2, 3, 4 small boxes there. Okay, so the 4 times the 0.04, right? 4 times 0.04, and that's going to get us the 0.16 seconds. So our PR interval is 0.16 seconds. So that is normal. Okay, and then we'll do the QT interval. So that's going to go from the start of our QRS complex to the end of the T wave. Right, so you see the end of the T wave where it's balancing back out to that isoelectric line is right about here, and we have the start measured here. So we got 2 small boxes, then we got 5, so that's 7, and then 2 more, so that is 9. Okay, we do the same thing, so it's 9 times that 0.04 for those 9 small boxes at that time, and that's going to get us 0.36 seconds. Okay, so remember our QT 0.036. That is normal, that is good. The last one on here is the QRS. Again, we'll find a spot. So we're going from isoelectric to isoelectric. So right there and right here, right? And that looks like 1, 2, maybe just shy of an extra half a small box. 1, 2, and I'll call it a half a small box. So 2.5, okay? So if we do that, the 2 times the 0.04, and that's going to get us to 0.10 seconds. Okay, so 0.10, and that is normal as well. As far as ischemia, we don't see any ST elevations here, right? If we look at all of our leads, the inferior, the laterals, precordials, and everything, that all looks normal. Also, when we look at that R wave transition between V3 and V4, we see it's happening right about at V3. Okay, so that is normal as well. So there's no ischemia, no issues there, and there's no other big irregularities. Okay, so this here, if we're going to describe it, would be a normal sinus rhythm. Okay, so it's normal sinus rhythm, and that's going at a rate of 79 beats per minute. Okay, normal axis, normal intervals, no signs of ischemia, no other irregularities to note. So we'll go into analyzing this next EKG. We see these 2 R's here are about the same distance from this big line. So we can count these big boxes. So it'll be 1 big box, 2 big box, 3 big boxes to get us about that same spot. Multiply that times 5, so we get 15. If we did the 1500 divided by 15, it's going to get us a rate of 100 beats per minute. Okay, and we could do that laddergram again if we wanted to. We would see everything's going to match up just fine. We got the narrow QRS and the P waves that are in there, right? So this is a sinus rhythm. As far as regularity, there's no irregularity in here. We could, again, march this out with the post-it note if we wanted to just do a little check mark. The axis, we compare one AVF, it's normal. Our intervals, okay, so we have our PR interval, the QT interval, and the QRS that we're going to do here. So the first one would be the PR interval. We find a pretty easy one is right about here, okay? And that's going 1, 2, 3, and then right at 4 here to get there. So that's going to get us a PR interval of that 0.16 seconds, which is normal. Okay, then we go to our QT interval. So again, we're going to start at the start of one of these QRS complexes. Okay, and we'll take this one here. So that's 2 small boxes to this big line, and then we can use this lead here. So that's one big box past that one. Okay, so that's one small box, and then we had so 5, so that's 6, 7, 8, and then maybe just a little bit past that if we want to get past that. And that's going to get us, we multiply that times 0.04, 0.32 to 0.34. Okay, and we'll call it 0.34 in this case, which is a little bit shorter, but that's okay. As far as the QRS, okay, we're going to look at that one next. So we'll find one up over here that matches up pretty good. So we have that line, and then where it actually equalizes out is right about in here. So that's 1, 2, 3, and then maybe just a little bit more than 3 boxes. Okay, so we multiply that times our 0.014 is going to be 0.14 seconds. So this is an issue, right? So this is already outside. As far as ischemia, okay, we look for those depressions or elevations, and we do see depressions in this. There's depressions on 2, a little bit on 3, okay, and then we look at AVF, V6, V5, a little bit of 4, and maybe a little bit here on 3. But if you remember, all of these are the inferior leads, okay, and the low lateral leads. So we note that, so the ST depression, okay, so ST depression inferior, and we'll do lateral, okay, and there is some anterior too, so we'll do that too, so anterior. And as far as regularities, we'll count that, right? But we need to look again at that QRS. So now if we remember what we talked about before, right? If we blow up lead 1 here, okay, we're going to have this kind of shape to it, right? It's going, and then it's coming up, and it's going like this, and coming down, and then it has kind of a slowing, or a slew kind of shape, right? And this shape here is that one that we were talking about earlier. So we're going to look for a bundle branch block, particularly the right bundle branch block, since we're seeing that instead of those mountain shapes on lead 1. Okay, so we'll look at V1, 2, and V6 and V5. It's not always in V1 or V6 where this is most obvious. Sometimes it's 2 and 5, which is why I look at those. In this case, V2 is the more obvious one, and we see these bunny ears, right? And they're happening here. Because they're happening on this side, this is a right bundle branch block, right? If we saw this over here in V6, that would be a left bundle branch block. So we can write that down. So we have a right bundle branch block, right? And then with that, we also have the R wave, so a poor R wave progression. But the reason that that's happening, okay, and possibly the reason that we're having these depressions that are showing up in here too, is that with an abnormal depolarization, okay, that happens with, say, a bundle branch block, you have abnormal repolarization. So what that means is that if we have elevation or depression or anything from the bundle branch block happening, that it's okay. We're going to see depressions in that case, okay, just as long as they're not following each other. So this hole in this case is likely related to the bundle branch block. Just remember, abnormal depolarization is going to cause abnormal repolarization, okay? And so that's what's going on here, but we'll still write that all down and pass this up. So our ending here, we got, again, this is a sinus rhythm, right? And we know the rate, it's at the high side of normal, but it is a normal rhythm. And normal axis, we do have a prolonged QRS, but we have a prolonged QRS because we have that with a right bundle branch block. All right. All right, so for this next one, as soon as we open it up, you see there's a couple different QRS morphologies going on, right? So we have this one here, we've got these that are kind of stretched out, and then we have this whole couplet or this pair here that's going on. For the sake of this, we're just going to focus on these guys here. Okay, so if we were to just cut this down and just use these as if they're going through the whole strip. So if we go and we do to R, we'd find that we have a rate of 71 beats per minute, okay? And that's going from this one and this one here, since this one's along the line. The next thing we do is, if you want to do a lettergram, you can see there's no P's in here. Okay, so there's no SA node firing. And because it's wide and there's no sign of a bundle branch block or anything, this is coming from the ventricle. So this is a ventricular rhythm, right? Ventricular rhythm, because it's arising from the ventricles themselves. For the sake of regularity, you could go march this out, and they're going to be regular to themselves. If we look at the axis isn't going to tell us too much because it is a ventricular rhythm. It can be useful for certain things, but in this case, it's going to be off. Okay, and that's just because the signal is having to wrap around that ventricle. So anytime, again, we have abnormal depolarization, we have abnormal repolarization, and we're going to have abnormal signals. Okay, so we'll use that, we'll write that down for the right axis deviation. If we do our intervals, the first one is the PR interval, right? Which we can't have because there is no P. Okay. The next one, if we do our QT interval at this point, we would go and march that out, and we're going to have a QT interval of 0.48, which is prolonged. Okay. And then finally, the next one we'll do is the QRS. And if we go and march these out, we'd have a QRS of 0.16 seconds. Okay. As far as ischemia, we do see that there is depressions here. Okay. But whenever we have a depression from a ventricular rhythm, it's not necessarily due to ischemia. It's more likely due to, again, that abnormal depolarization. You can't use a paced rhythm necessarily, or the ventricular complexes like this, to be able to accurately describe ischemia. Okay, and that's because the ventricular signal, as it wraps up and around there, that abnormal depolarization again is going to throw that off. So if you ever have somebody who's, say, got a pacemaker, there is the possibility to be able to look at it if there's extreme differences there. But for something like this, it's kind of expected. We can't say anything about ischemia. Okay, so we're just doing X there. Just because it would still need to be ruled out if this person was presenting to the emergency department and they did have chest pain. You need to do further tests and everything. As far as the irregularities, again, we could note that we have all these different complexes. For this portion here, the only irregularity is just the fact that it's ventricular. Okay, and again, we're discounting these for the sake of this strip. So when we're describing this, okay, we do have a ventricular rhythm. Okay, and we use that nomenclature we used before. So we have ventricular rhythm, and then we look at our rates. That's 71 beats per minute. Okay, so the intrinsic rate for the ventricles was 20 to 40. Remember, tachycardia was greater than 100. So we're between that number, which means it's accelerated. Okay, this is an accelerated ventricular rhythm. This may also be called an accelerated idioventricular rhythm, more commonly. And that's just saying that idioventricular is saying that the ventricles are contracting themselves or sending the signal to themselves, right? And most common, you'll see this in the parentheses, AIVR. All right, and now we go into the next one, which you can already see there's some weird stuff, and that's why we're going to go through that systematic approach for this. So for starters, we're going to go and figure out the rate, which I'll use this guy here to here. That gets us about 13 small boxes, or a heart rate of 115 beats per minute. Okay. The next thing for figuring out the rhythm is going to be a bit more tricky here, because we see there's P waves, right? But these are upside down, right? So remember, at this point, I said we can use AVR, right, and lead 2. So AVR, it should be negative, right, because it's going away And in lead 2, it should be positive because it should be going towards the positive at that point. But in this case, it's flipped, right? So if this is positive in AVR, that signal, okay, is coming upwards. Okay, it's going towards AVR this way rather than going from the SA node and down. It's coming towards the lead, so possibly even away from the SA node. So if we go and draw this out again real quick, we see the ventricles narrow, right? It's coming from the AV node, but it's very, very quick. There's a very, very short pause in between these, and it's not coming from the SA node. Okay, instead it's coming from somewhere else. So we'll do this here. And because it's so short, it's actually too short to the point the AV node isn't actually able to hang on to it and send that. So in this case, this signal is kind of going backwards like this. It's actually the AV node has started here, and it's sending back a signal, and then that's passing on to the ventricle shortly after. So this is arising from the AV junction. So this is a junctional rhythm. Okay. As we explained before, these P waves, right? It looks like a P wave can either be really close, it might be tucked into the QRS, or it might happen after the QRS. Because regardless, what's happening is the AV node is starting its firing here, right? It is started. It's hanging on to its signal, but it's sent this signal back right as it's getting ready to send it down to the ventricle at the same time. So it's arising from here and going in both directions at the same time. Okay, so this is arising from the junction. As far as regularity, they are regular. The axis here, it's actually a left axial deviation. Okay. The intervals we can march out. So the PR interval is incredibly short. It's actually, if we do that, it's somewhere around 0.08 to zero point 0.1. Okay, so PR interval 0.08, and then our QT. In this case, if we were to again march this out, it's not too bad. It's right about that 0.36. Okay. And then our QRS is narrow. It is right about 0.1. Okay. As far as ischemia, we don't see anything weird on here. R wave progression is again okay. It's happening right at 4 as our transition point, and there's no obvious ST elevation or depression or anything. All the T waves are upright. There's nothing weird going on like that, so we don't have any irregularities there. So from here, we can go into actually naming our rhythm, right? Use that same nomenclature we used before, so we know we're starting with that junctional rhythm, okay? And then we look at our rate, okay? So immediately our rate is greater than 100, okay? So this is junctional tachycardia. And that's going to be at a rate of the 115 beats per minute. You can add on normal R wave progression. There is left axis deviation, normal R wave progression. No signs of ischemia. And we're going to do this one just like all the others. So we got this one, it's sitting up along that big line, it's easiest to use. And if we march that out, we'd find that our rate is 88 beats per minute. Okay. We see that there's a P for every Q, and those match up. So it means we have a sinus rhythm. There is regularity. The axis, we see both are up there, 2 thumbs up. So we have a normal axis. Okay. So for the intervals, we have our PR interval. If we were to go and march this out, the easiest one to do it in this case is lead 1. We have a PR interval of 0.14. The QT interval, if we use this one again, is the easiest one to see it to go out to where it goes down to 0 there, is going to be 0.38. Okay, and our QRS is 0.10 seconds. Now the big thing with this one here is when we get to the ischemia portion, we do see elevation, right? We see this ST elevation, the J point elevation here leads 2, 3, and AVF. So that does mean we have inferior elevation, right? So I'm just going to write that down for starters. So inferior ST elevation, right? and we don't have any abnormal depolarization from ventricularization or anything going on. So the next thing we have to look at with this is that if we have an injury on one side of the heart, we're going to see the opposite action on the opposite side of the heart. So with the inferior leads, right, if we were to draw our heart out again here, right, if we remember the inferior leads are looking like this and they're looking down. So if we look at leads that are opposite to those, which are going to be facing out this way, it's going to be our lateral leads. Okay, so if we have elevation here that's going up, if we have ST elevation over here, we're going to have the opposite effect over here. So we're going to have elevation inferiorly, we'll have depression on the lateral aspect, and vice versa. If we have elevation to the lateral leads, we have depression on the inferior leads, and that is called a reciprocal changes. In this case, if we look at leads 1, okay, lead 1, we see there's depression there, and AVL, actually, it's more obvious. This also helps us triangulate exactly where that infarct can be, since AVL looks higher up this way than lead 1. We see that the area of infarct is going to be a bit further down up in here. Okay, so we do have some reciprocal changes. So we'll do with reciprocal changes. Okay, and as far as irregularities, that's the main irregularity. As far as our R wave progression, that is still okay. It's still happening at V3 right there. Right, so that's all right. As far as us going to say our rhythm, this is a sinus rhythm. Okay, we look at the rate, it's normal, it's within that 60 to 100, so it's a normal sinus rhythm at 88 beats per minute. However, we do have ST elevation inferiorly with reciprocal changes, and this would be a inferior STEMI. Okay, that is an inferior ST elevation myocardial infarction. So this is the big bad one. It's really important to know. And then for cath lab and everything, you triangulate this more to figure out which artery exactly is the one that's being affected.